Thank you, Raman, and it's a pleasure to be here again. I'm really thrilled and honored to be with two directors of endoscopy from great institutions and be up here on a panel with them. So thanks again for having me for this topic. So hopefully you've noticed, but we're in a pandemic. So here's a map of this pandemic, the last 9 or 10 years. You can see that the colors are getting redder and redder. They're getting darker. And at some point, we're going to probably have to add new colors to this map. And from the topic of this talk, you've probably figured out I'm not talking about the COVID pandemic, but the other pandemic, which is really staggering, and it's obesity. As a chronic disease, in 2020, we passed over 40% of adults in the United States with obesity. So we're talking millions and millions of patients. And then what about everyone else that's overweight? And of course, we use the BMI for definitions of obesity, so 30 and greater. But what about those who are overweight, like my family members who maybe are not even overweight, but they are struggling with diabetes and NASH and other metabolic conditions? What are we doing? And how many millions of patients are there? And so the other part of it is hard to think about any medical specialty that is not affected by this, whether you're an orthopedic surgeon, GI, you're an OBGYN like my wife, mental health experts, et cetera. It affects everyone. And probably this is an underestimate that nearly 1 in 5 deaths were associated with some kind of obesity-related comorbidity. And if we measure obesity as a disease condition, similar to that we do to other disease conditions like heart failure or infection prevention, surgical site infections, or other kind of quality metrics, our performance is, I wrote up here suboptimal, but frankly, it's terrible. And you just look back to that map that I showed you earlier. So what are our options? Right now, the foundation remains diet and exercise. There's medications, I'll mention a few of them. And then surgery really is probably the best and remains the best option for patients struggling with obesity. With diet and exercise, nothing I'm going to mention in this talk works without this as a foundation. It's vitally important. That's why I've had several conversations with our dietitians and dietitians from other groups at UCLA, but this doesn't work for everyone. And all you have to do is look at that map that I showed you in the beginning, getting redder and redder. Exercise is vitally important, but it's actually very hard to lose weight with just exercise. The diet is as important. And probably what exercise does is it has other benefits, such as, for example, leptin resistance and of course, muscle mass and the benefits of having that rather than fat. But it just doesn't work for so many people. With medications, there's a lot of promise now. We heard a little bit about this yesterday with the NASH talks, but the GLP-1 agonists, liraglutide and semaglutide, really have started changing the game with what we can do with medical therapy. And with semaglutide, we're talking about a weekly subcutaneous injection, but the total body weight loss, 15%, was as high as some of the endoscopic treatments that I'm about to show, and really can be game changer, particularly if you start adding them to what we can do with interventions. Falling out of favor are kind of some of the older medications, such as phentermine and others here, for one reason or another, often side effects. And I think that this has given medications for weight loss a little bit of a bad rap. But I think there's a lot of promise, and particularly when you think about what we can do with combination therapy. Now, surgery is highly effective. And right now, and it seems like things go in cycles, but right now, the most common and popular is the vertical sleeve gastrectomy or laparoscopic sleeve gastrectomy, where a portion of the stomach is removed, the outer portion. The alternative is a Roux-en-Y gastric bypass where the stomach is formed into a pouch. And then there's a kind of a reconfiguration of the plumbing. And this has profound effects because we're bypassing the first portion of the duodenum and the duodenum and the first portion of the jejunum. And even independent of weight loss, we start to see profound improvements in diabetes measures and probably other incretin and hormone-related effects. And so keep these pictures in mind because I'm going to talk about some kind of mimics that we do. But these are highly effective. And depending on if you're reading the surgery literature or the GI literature, there's a couple different ways that we typically report weight loss. One is excess weight loss, which takes a little bit of math. Much easier for most people to understand is total body weight loss, just what % of your body weight. But these are the kind of numbers we're looking at with surgery. Very, very good. Now, the problem is how many patients get surgery? Well, here's the data from the Bariatric Society. And you can see that a couple of years ago, it's about 250,000, most of which were sleeves. Then there's the gastric bypass. And then down here is a revision. So someone who's regained weight after prior surgery. And I showed a video of endoscopic version of that yesterday. But Think back to the number I talked about at the beginning. We're way off. 256,000 out of millions and millions of people who qualify. There's millions more that don't qualify. And typically for surgery, patients have to have a body mass index of 40 or greater. So we're talking about class 3 obesity, or 35 and greater with some kind of obesity-related comorbidity. That may be 1 or 2, depending on insurance company. Now you can get surgery without having to have those or meet those qualifications, but you're looking at out of pocket. So for example, a local rate that I know is $25,000 to get a laparoscopic sleeve gastrectomy, or I have patients that fly to Mexico and get it done cheaper. And so there's patients that want this, but access is still quite poor. So what are the barriers to all of the things I just mentioned? Well, with diet and exercise, and diet in particular, there's a yo-yo effect. So diets can work very well, but it's hard to keep it off. And the reason is that the body is fighting against you. So for ease, I've kind of put some of the main hormones that are involved. Red, ghrelin, is an appetite stimulator, and then these others, but the ghrelin fights against you. So the hormones kind of are fighting the behavior change. After that, with medications, I think, as I mentioned before, the medications got a bad rap, and that's because of the side effects of the prior medications, the older agents. There's a lot, with the stories about fen-phen and other side effects like that. Cost, you got to take them continually. So there's problems. And of course, there's the injection issue as well. And surgery is just too aggressive for some people. As I mentioned, there's many people that don't qualify. And I wrote 3%, but probably it's really less than 1% when you think about those numbers I just showed you. And what about everyone else that doesn't qualify for surgery? This isn't working. So surgery is the gold standard. It's the best. It's the most durable. We have plenty of data. But can you really call something effective or gold standard when less than 1% of people who qualify are not able to get it or don't get it? And so I worry about this entire field that we keep. The question everyone asks is, how do the endoscopic therapies compare to surgery? That's a false equivalence. We need to be comparing it to the reality, not to surgery. The reality is that, unfortunately, we're kind of losing this battle right now. And then what about all those people who don't qualify for surgery? What about the patients who are just overweight or maybe not overweight and have fatty liver? They may have diabetes, other conditions that are related to metabolic syndrome. And then those people that they qualify and they just don't want it. It's too aggressive. The plumbing changes are too much. So we need a strategy shift. We need a thinking shift. And you look at kind of this best treatment, surgery, and you can kind of see how it works and maybe use that to guide what we do. And so classically, the surgeries are thought of as restrictive procedures. You're essentially remodeling the stomach with a sleeve by removing it, or with a gastric bypass by making a small pouch. And then with the bypass is a malabsorptive procedure, which it probably mostly affects fat malabsorption, but also has some other measures. And so those are the classic thought, but actually we've learned a lot more. There's major neurohormonal changes with gastric bypass and with gastric sleeve. There's changes in motility. There's alterations in the microbiome, in the way that we process bile acids, and probably a lot more. This is still a field that we're learning a lot. And so, but you look, and can we mimic some of these surgical changes? Well, what are those changes? Well, restriction may trigger some kind of hormonal response in the stomach by just causing stretch. If you tighten things up, maybe you'll get some more food pooling in certain areas and affecting stretch receptors. Gastric motility. Neurohormonal changes in the stomach and the small bowel. Can we somehow induce some controlled malabsorption? Those are the kind of the ways, these are the ways that the surgeries work. So can we do that endoscopically? And so the way that I look at these novel therapies that I'm about to go through is, number one, the foundation is the most important thing. You need to collaborate, and building a team around you, dietitians, endocrinologists, hepatologists, surgeons, certainly, social workers, mental health, all is very important. But we need to make it easier to access those specialties as well. Number two is set realistic expectations for patients. So I tell them the data, but remember that whenever you're presenting an average, there's half of people do worse, half of people do better. And the X factor is what else we're doing. So these procedures, I treat them more of a kickstart, a tool, and by themselves, they're not going to do it. And what else we're doing, it's just one piece of the puzzle, is actually much more important and probably a lot harder. And number three, this false equivalence. The data will be generated, but as a field, as a medical field, we need to stop saying, okay, well, how does it compare to surgery? No, we need to say, how does this compare to reality? And the reality is that there's a lot of people that are struggling with diet and exercise. They're not losing the weight, and it's just not working. And so that's kind of my mindset. It's really an approach to the way we think about it. are these better than what we're doing now? And what we're doing now, it's just not working very well. So this is kind of the menu of options that I'm going to discuss. A couple of these are investigational. I'll mention them at the end. With primary endoscopic procedures, we're talking about the endoscopic sleeve gastroplasty. An important study that just was presented last year, a randomized control trial out to 2 years, showed 49% excess weight loss at 12 months. And that's compared to moderate intensity lifestyle modification of about 4%. So again, that's still not the reality. That's with an intervention of trying to get a moderate intensity lifestyle modification. And the total body weight loss is about 16%. And a lot of the prospective series are quoting between 16 to 20%. So those are the numbers I kind of talk about. And most patients were able to achieve these kind of metrics that we've set for ourselves to consider something valid, which is the 25% excess weight loss. We have 5-year durability data. And so the patients that get the weight off initially tend to keep it off. And so, as the procedure becomes more common and as time passes, we may see more of this. And then more importantly, I think it's important, and we're understanding now that it's not just about the restriction and changing the size of the stomach and turning it into a sleeve shape. And you can see some of the suture patterns on the right side where we'll U-type stitches and kind of scrunch things down and make it into a tube or a sleeve. But we're seeing that it's not just about the anatomy. It's about the metabolic system as well. So we see from a motility standpoint, gastric emptying delay, the ghrelin, which is that appetite stimulator, does go up kind of in a compensatory fashion, but then actually will start to come down at 1 year. And so the gastric remodeling, just by stitching it, changes something about the neurohormonal pathway. And then there's other kind of incretins and hormones that we're seeing beneficial changes as well. So just plicating the stomach, folding it down, scrunching it up, however I want to describe it to patients, is more than just making it smaller. There's other things that are happening. This is the suturing system. We've seen a few examples in the video forum yesterday. The one on the left requires a double channel scope, but there is a single channel scope as well that could fit on a standard gastroscope. There are other full thickness plication systems that are currently investigational, now approved. So we may see some of these being used as well. And then another kind of primary therapy are intragastric balloons, which are really space occupiers. I won't go too much into detail. It's available. It's a fast procedure. It just takes 10 minutes to quickly fill up a balloon. They must be removed after 6 months. They kind of had a little bit of a bad reputation. There were a few bad outcomes, including a fatality. But when you look back at what happened, it's super important to choose the patients wisely. And there's certain absolute contraindications. So when done correctly, when done responsibly in a multidisciplinary setting, they can be highly effective. The downsides to them is they can be difficult to tolerate. And the side effects are such that about 16% of patients may require early removal, just that they can't tolerate it. And then when you remove it, there is a high rate of weight recidivism out to 2 years. And so the really advantages of this were, okay, well, it's removable, you're not changing anything, and it's quick procedure. But I think my surgeons have operated on patients who have had endoscopic sleeve gastroplasty, the ESG procedure, and they work their way around the stitches, and they find a way, even in a patient that I've done a primary ESG on. And so the further I kind of go through this field, the more and more I think that I don't see a reason why a patient considering this shouldn't just have an endoscopic sleeve gastroplasty with the long-term durability, the better side effect profile, and it doesn't really take anything off the table. Now, I'll just briefly go through revision procedures. I showed you one yesterday, but it's for patients who have gained weight after prior gastric bypass surgery. That rate is in the double digits, sometimes as high as 20 to 25%, and in some studies, even as high as 37%. The surgery, the revision carries a higher risk than the initial procedure. And also, it doesn't seem to get as much weight loss as they did up front. And so the endoscopic revision was designed as a way to try to make it a faster, safer approach. And so my procedure time is typically 30 to 50 minutes, depending on if I'm adding a gastroplasty to the outlet reduction, or if it's a gastric sleeve revision, and a same-day discharge. We discussed the transoral outlet reduction yesterday, but the 5-year total body weight loss appears to be similar to surgical revisions. And there's no direct prospective head-to-head, but on retrospective studies, and then just looking at the durability data, it doesn't seem that you're getting much more with surgery over this. And one I've discussed it with our surgeons, and it's probably because, like we talked about yesterday, a lot of those hormonal changes that were already done by redoing the plumbing and changing the anatomy have already taken effect. And lengthening the limb may not get you as much extra bang for buck by on that aspect, but could get some more malabsorption from the limb length change. So really, this is mostly focusing on resizing the stomach, which is the other part of a revision procedure. And it's a very low adverse event rate. Most of these are kind of in the form of pain and nausea, which I describe just as part of the process. We've started in the last couple of years offering serial revisions for people who have, maybe it doesn't work so well. And so we're starting to present that data. And then, as we alluded to yesterday, gastric sleeves can also be revised. And it's essentially doing an endoscopic sleeve gastroplasty. And you could see here that, again, the total body weight loss are similar to what you would see with a surgical revision, but it's significantly safer, easier, faster procedure. And so at UCLA, essentially any patient that comes into the bariatric surgery clinic looking for a surgical revision, I'm extremely grateful to our bariatric surgeons, but they give us first shot. And this doesn't take anything off the table if it doesn't work. Now, shifting a little bit is to the other side of this, which is metabolic endoscopy. And I'm going to talk about this device. It's essentially a balloon with 4 needles attached to it. The needles are used to do a submucosal injection in a 360 fashion in the duodenum, about a 10-centimeter segment. The balloon is inflated, and then hot water is pumped through it for 10 seconds at a time. And this is called duodenal mucosal resurfacing, or hydrothermal ablation. You're essentially protecting the wall of the duodenum and burning the inside with hot water. And this is to mimic some of the changes with the bypass. If you remember, with the gastric bypass, that area is bypassed, it doesn't see food. Well, the theory was here that it's something about the lining of the small intestine that is vitally important for those hormonal changes. And so important study just published, hot off the press, that 34 patients now followed out to 2 years not in the United States, but they saw after one procedure, a hemoglobin A1C drop of nearly 1% out to 2 years. And that's as good or better than adding a second or third diabetes agent. So very promising data. And then we're also seeing improvement in insulin resistance, decrease in ALT for NASH, and some weight loss, and as well as increase in kind of HDL and triglyceride ratio. So we're hoping to become a study site for this. The pivotal randomized control trial in the United States is underway. And then I'll close with kind of where else are we going? Can we do an endoscopic gastric bypass? Dr. Sethi yesterday talked to us about accessing different areas of the GI tract with EUS. This is an animal model where they actually straight up did a Notes procedure and actually went out of the stomach and used a lumen-opposing metal stent to connect a loop of small bowel to the stomach and then plugged the pylorus. So thinking back to what's going on with the gastric bypass, if I have a length of jejunum somewhere down here, can I take a lumen-opposing metal stent, pop it in from here to somewhere down there, and then plug the duodenum at the pylorus? And essentially what I've done is recreated the same system of a gastric bypass, which is a gastrojejunectomy and a bypass of the proximal small bowel. So the animal lab is studied, and I'm excited to see what may come of this as we get more proficient with gastrojejunectomy. So where do I see this going? Metabolic and obesity treatment of the future. So a patient comes in, and they see a multidisciplinary team of experts. And that could be a lot of different specialties, but we put our heads together and we decide what's the best way to triage this patient. And the patient is presented with all of their options, including the diet and exercise. We find something that works for them. They may meet with a surgeon if they've considered surgery. They may meet with me if they're not a candidate or they just don't want surgery. And then they might see colleagues to try medications with or without any of these procedures. So for example, you take a patient with a BMI of 33, diabetes, and fatty liver, and why can't they undergo a combination of treatments, including an endoscopic sleeve gastroplasty, maybe eventually a duodenal mucosal resurfacing procedure, and then regular multidisciplinary follow-up visits to start semaglutide medication that may help with their diabetes and maybe a little bit of weight loss and potentially fatty liver, as we heard from Dr. Benhamou yesterday. The barriers, I think, are, is this the latest fad? And there's a lot of procedures and techniques that have come and gone. So we need to continually study and refine our techniques. And I think it's also good to be responsible and not overdevelop this so that way the data doesn't get muddied by potentially lower quality. So training and potentially setting up centers of excellence like they already have in bariatric surgery may be important. This whole concept of, am I competing with the surgeons? First of all, 99% of patients don't ever make it to surgery, and that's not including the patients who are just class 1 and class 2 obesity. So it's a completely different pool. And there's millions of patients, plenty to go around. And universally, every center that I've discussed that has started a bariatric endoscopy procedure has increased their surgery volume, potentially up to 25% in some cases. And then finally, probably the most important thing and the hardest is setting up that multidisciplinary team. I think that hopefully I've convinced you this is a staggering problem. It's a pandemic, and we need to really respond to that gravity situation with giving the right resources to the right places. So with that, thank you for your time. And at the panel, I think we'll have time for questions.